Biopsy. That's not a lottery number. That is the number of people out of every 100,000 seniors on a common bone medication who develop a fracture. Not from a fall, not from a car accident, from the medication itself, a medication prescribed directly because of a routine medical screening. And here's the part that will stop you cold. The screening was called standard care. Think back to your last physical. When did your doctor last order a test, not because you had a symptom, but simply because it was time to check? If you're over 65, there's a real chance that at least one of today's 5 checkups was on that list. And here is what almost no one puts on the consent form. After 65, your body's relationship with medical procedures changes at the cellular level. Not because you're fragile, but because a biological process, one that most screening protocols completely ignore, has fundamentally altered how your tissue responds to physical intervention. Today I'll show you the science behind that shift. Then we'll go through 5 specific checkups where that science means the risk math looks completely different from what you've been told. My name is Dr. Mason. I work in internal medicine and geriatrics. What I'm about to share isn't opinion, it's mechanism, it's data. In 2019, Nature Medicine published research that changed how a generation of geriatricians think about aging and invasive procedures. The science confirmed what many of us had already seen in clinic. As we age, senescent cells, what scientists call zombie cells, accumulate in our tissues at an accelerating rate. These cells stop dividing. They're not dead, they're stuck. And they release a cascade of inflammatory chemicals called the senescence-associated secretory phenotype SASP. Think of SASP like a factory that never shuts down, constantly pumping low-grade smoke into the surrounding neighborhood. That smoke doesn't kill immediately, but over time, it slows tissue repair. It reduces collagen synthesis. It increases inflammation at every site of injury. And here is the clinical implication that changes everything. When your tissue receives physical trauma, even the controlled, intentional trauma of a medical procedure, it heals more slowly after 65, sometimes dramatically more slowly. That longer healing window is where complications live. This is the biology almost no one explains before you sign a consent form. The trap doesn't arrive with sirens. You don't feel the senescent cells accumulating. You don't feel your collagen repair rate declining. You feel fine. You look fine. Your doctor checks boxes on a standard panel and then says, "The result looks concerning. Let's investigate further." That is when the cascade begins. Let me tell you about Harold. Harold is 73, a retired plumber from Cleveland. Been restoring classic cars in his garage since 1999. Wakes up at 6:15 every morning, walks 3 blocks to the diner for his coffee. No chest pain, no blood in his stool, no symptoms of any kind. At a routine physical, his doctor ordered 5 standard screenings. By the time Harold had completed the follow-up procedures triggered by those results, he had experienced 2 separate complications, neither caused by his original conditions, both caused by the screenings themselves. Harold is not exceptional. He is representative. Here are the 5 checkups that changed his health and that may be quietly changing yours. The first checkup to reconsider after 65, the routine colonoscopy. I want to be precise. For adults between 45 and 75, colonoscopy is a powerful tool. I'm not telling you it's useless. But the evidence for routine colonoscopy beyond age 75 inches patients without prior polyps or family history of colorectal cancer is weak, and the risk profile shifts in ways most doctors don't have time to fully explain. Here's what actually happens in your colon during prep. The solution, polyethylene glycol, forces rapid, complete evacuation. In older adults, this creates significant electrolyte disruption. Kidneys over 65 filter blood more slowly. Imbalances that a 4-5-year-old corrects in hours can persist for days in a 7-3-year-old. But here is the deeper biology. Colonoscopy involves direct contact with your colonic mucosa, the inner lining of your colon. Any biopsy, any polyp removal creates a small wound in that lining. In a 4-0-year-old, the fibroblast cells that seal those wounds divide and proliferate rapidly. After 65, those same fibroblasts show a 40 to 60% reduction in proliferation rate. Think of it like a road repair crew that used to show up with 10 workers to fix a pothole. After 65, only 4 workers arrive. The pothole still gets fixed, but the window of vulnerability is longer. And during that longer window, everything that passes through carries more risk. Every biopsy site in your colon heals more slowly. The window for bleeding is wider. The sensitivity to normal colon bacteria is greater. Perforation rate from colonoscopy in patients over 80 is 2 to 3 times higher than in younger adults. And for adults over 75 without prior adenomas, the probability of finding cancer that changes their treatment course is under 1.5%. The risk of the procedure is multiple times the probability of a game-changing finding. The question your doctor should ask first, but often doesn't, is, if we find something, what would we actually do about it? Is that treatment realistic for you? That answer changes everything. The second checkup, the PSA blood test for prostate cancer. Here is the number I want you to hold: 75%. That is the false positive rate of an elevated PSA in older men. 3 out of 4 seniors who get flagged do not have clinically significant prostate cancer. But what happens after a flagged PSA? A prostate biopsy. 12 large bore needles through the perineum into the prostate gland. Standard procedure in men of every age. Except what changes after 65 is this. Prostate biopsy carries a 2 to 4% risk of bacteremia, gut bacteria entering the bloodstream even with antibiotic prophylaxis. In a 4 or 5-year-old, the immune system clears it in hours. In a 7-2-year-old, a process called immunosenescence, the age-related slowing of immune communication means that same exposure carries meaningfully higher risk of escalating to systemic infection. Think of it like a security team with slower response time. Not because they're absent, but because the radio signals between team members slow down after decades of use. A threat that gets contained in 15 minutes at age 45 takes 45 minutes at age 72, and a lot happens in that extra half hour. Do you understand what that means? The most common finding from PSA-triggered biopsy in older men is Gleason 6 prostate cancer, the slowest growing category. Most urological guidelines now recommend active surveillance for Gleason 6, but the psychological weight of a cancer diagnosis in a 7-3-year-old often drives treatment. And radiation or surgical treatment carries 20 to 30% rates of permanent incontinence or erectile dysfunction. The USPSTF gives PSA screening in men over 70 a grade D recommendation. Your doctor may not mention that. Third checkup, the cardiac stress test ordered when you have no symptoms, no chest pain, no shortness of breath, no signs of cardiac compromise. Just, let's see how your heart is doing. The U.S. Preventive Services Task Force assigned this a grade D rating in 2018. That's their highest level of discouragement. Do not perform in asymptomatic adults. Here's why. In seniors who cannot run on a treadmill, pharmacologic stress agents, adenosine or dobutamine, are used to artificially spike heart rate. More than 50% of adults over 70 have some degree of diastolic dysfunction, a stiffening of the heart muscle that changes how the ventricle relaxes between beats. When you pharmacologically stress that heart, you're not replicating normal exercise physiology. You're creating an unnatural demand in a cardiac system that's already operating differently. This elevates arrhythmia risk during the test itself. And then there's the cascade. A borderline stress test result leads to nuclear cardiac imaging. Nuclear imaging means radiation exposure. Nuclear imaging with changes leads to cardiac catheterization. Catheterization carries a 0.1 to 0.3% rate of serious complications during the procedure, including stroke and heart attack. Has any study shown that finding and treating silent coronary disease in asymptomatic seniors reduces mortality? None has. The cascade creates risk. The treatment of findings creates risk. And the end outcome measured in years lived and quality of those years shows no documented benefit. Let me pause here. Everything I've shown you so far follows the same pattern. Routine test, elevated result. Follow-up procedure, complication that wasn't from the original condition. This is the Diagnostic Cascade Burden. Researchers at Dartmouth documented it. Patients in high screening regions underwent more procedures and more hospitalizations and had equal or worse health outcomes than those who received fewer interventions. More screening doesn't equal better health. After 65, it can mean the opposite. This brings us back to Harold. Harold's DEXA showed bone density below threshold. His doctor immediately prescribed alendronate of bisphosphonate. Harold was never told what bisphosphonates actually do to bone tissue over time. Here's the mechanism. Bisphosphonates are incorporated permanently into bone matrix. They suppress osteoclasts, the cells that break down old bone tissue. That sounds right. Suppress breakdown. Bones stay denser, fractures decrease. But bone is living tissue. It requires continuous cycles of breakdown and rebuilding to stay structurally sound. Osteoclasts clear out microdamaged zones. Osteoblasts fill them with fresh, strong collagen. Suppress that cycle, and you get something that looks healthy on a scan, but isn't. Think of it like a building where the maintenance crew is permanently laid off. The structure looks fine from the street, but inside, the damaged load-bearing beams are never replaced. Over time, under stress, the building doesn't bend, it snaps. After 5 to 10 years of bisphosphonate use, the rate of atypical femoral fractures, fractures that occur with minimal trauma, sometimes just from standing up, rises to 117 per 100,000 patient years. Iba you should see. That number from the opening of this video, that was this medication. That was Harold's medication. Additionally, osteonecrosis of the jaw, where areas of the jawbone die from the same suppression of bone remodeling, becomes a documented risk with prolonged use. 1 DEXA scan, 1 prescription, years of altered bone architecture. Not because the doctor was wrong, because the long-term biological effects were never part of the initial conversation. The 5th checkup, carotid artery ultrasound when you have no symptoms. No dizziness, no weakness on one side, no neurological events, nothing. This test looks for plaque in the arteries that supply blood to your brain. The USPSTF in 2021 assigned it grade D for asymptomatic patients. Here's what ultrasound cannot tell you. There are 2 fundamentally different types of atherosclerotic plaque. Stable plaque, fibrous, calcified, lipid poor, does not cause stroke. It narrows the artery, but it does not break apart and send clots to the brain. Vulnerable plaque, lipid-rich, inflamed, thin-capped, is the plaque that ruptures and causes stroke. Ultrasound cannot reliably distinguish between them. When the ultrasound finds significant plaque, the standard treatment recommendation is carotid endarterectomy surgery to remove it, under general anesthesia, involving incision, dissection, and temporary clamping of the carotid artery. In asymptomatic patients, that surgery carries a combined 1 to 3% risk of stroke or death from the procedure. Think of it like this. A mechanic finds surface rust on a structural beam in your car. He says we should replace it now, before it fails. But accessing that beam requires removing the brake assembly with a 2% chance of damaging the brakes in the process. Is the risk of untreated rust higher than the surgical risk for stable plaque in a 1-year-old with no symptoms? The evidence says usually not. And in aging vasculature where atherosclerotic changes exist throughout the circulatory system, not just the carotid surgical manipulation at one site carries risk of dislodging emboli from other sites. The surgery meant to prevent stroke can trigger it. So what do? You don't walk away from medicine. You walk into it more intelligently. Before any screening, ask these 5 questions. 1. What is the false positive rate for this test in patients my age? 2. If something is found, what is the treatment plan? Is it appropriate for my overall health? 3. What are the procedural risks of the follow-up intervention? 4. Is active monitoring an option rather than immediate intervention? 5. What does the evidence say this screening improves in patients my age specifically? These questions take 90 seconds. They transform the conversation. A doctor who welcomes them is the kind of partner you want managing your health after 65. Harold asked these questions. 12 months after his original cascade of screenings, he found a geriatric specialist. He stopped the bisphosphonate. He declined the follow-up catheterization his first cardiologist was recommending based on a borderline stress test result. His new cardiologist's assessment: borderline normal. Harold is still walking 3 blocks to the diner, still working on the 1968 Mustang. He didn't push back because he distrusts medicine. He pushed back because someone finally explained the biology to him. That is the only difference between his first story and his second one. 5 screenings, 5 cascades, 1 biological truth. After 65, your tissue heals more slowly. Your immune response is less rapid. Your bone remodeling is suppressed by the very drugs designed to strengthen bone. Your cardiac physiology is already operating differently, and routine medical protocols built largely on evidence from younger populations don't automatically account for that. Colonoscopy after 75. Slower mucosal repair means biopsy wounds stay open longer than the risk of finding actionable cancer justifies. PSA testing. A 75% false positive rate drives biopsies that immunosenescence turns into higher risk procedures, triggering treatment for cancers that will never cause symptoms. Routine stress test. Pharmacologic cardiac stress in diastolic dysfunction creates arrhythmia risk, and no trial shows asymptomatic finding treatment improves senior longevity. Frequent DEXA and bisphosphonates. Suppression of bone remodeling builds paradoxical fracture risk at the 5 to 10 year mark, the opposite of the intended outcome. Carotid ultrasound. Stable plaque and vulnerable plaque look identical on ultrasound, and endarterectomy risk in asymptomatic seniors often matches or exceeds the natural stroke risk. If this changed the way you think about your next physical type, the word screen in the comments below. I want to know how many of you have had at least one of these 5 tests in the past 2 years. If you found this valuable, share it with someone over 65 who trusts their doctor completely. They deserve this information too. Subscribe if you haven't. Every week, the biology your annual physical doesn't have time to cover. Next week, the 5 symptoms that seniors dismiss as normal aging, but that are actually early signals of conditions that respond dramatically to intervention. Knowing what to push back on and what to act on immediately may be the most important medical distinction you ever make. I'll see you there.